Hi everyone, welcome back to my channel. In part 1, we finished with all the possible specimens we could do in obstetrics. And now we're going to start with all the specimens of gynecology. So, identification of organ. How are you going to identify uterus? It is identified with the following. It is a pear-shaped structure, adnexal attachment, cervical os is circular in nulliparous and transverse slit in Paris women. Anterior surface of uterus is identified by the following: attachment of the round ligament, loose attachment of the uterovesical fold of peritoneum to lower uterine segment. Uterovesical, obviously. Posterior surface of uterus is identified by the following: attachment of the ovarian ligament with ovary, cut margin of posterior peritoneum densely attached to the posterior surface and placed at a lower level than the cut margin of anterior peritoneum. Structures attached to the uterine cornu are the following: round ligament, a cord-like structure attached anteriorly and running laterally and downwards. Fallopian tube, a tubular structure identified by fimbria at the abdominal ostium. Ovarian ligament, a short cord-like structure, the most posterior structure attached to the ovary. Ovary, fallopian tube may may not be attached to the ovarian specimen. There is no other pelvic organ resembling it. So you can't get confused with some other organ. So now let's move on to the next specimen, which is fibroid uterus. That's not how you start. Anyways, this is a cut section of specimen of uterus. Adnexal structures are not seen. The uterus appears enlarged. Uterine shape is distorted by a well-circumscribed subserosal growth that has a whorled appearance. You have to say whorled. And is surrounded by a pseudocapsule. Describe the size, number if multiple growths are present. So if there are like two, then you have to describe each of them. Diagnosis क्या है? Subserosal fibroid is the most likely diagnosis. So these are the questions that can be asked in your Viva. What are the different types of fibroids? Depending on the location, different types of fibroids are the following. It can be interstitial or intramural, subserous and submucous. What would be the probable age of a woman for whom hysterectomy has been done? Normal ovaries are usually removed during hysterectomy at after more than or equal to 50 years. Ovaries are not visualized in the specimen. Oophorectomy had not been done. Hence, the probable age of the woman would be less than 50 years. Oh. So, if the specimen has uterus and ovaries, then you have to say that. Then the probable uterus is more than 50 years. More than or equal to 50 years. So, if it's just the uterus, then you'll say that ovaries, so they are still inside the woman. And if you can see both ovaries and uterus, so matlab, they have removed everything, right? Matlab, uterus and ovaries. So the woman is probably more than 50 years old. What are the causes of menorrhagia and fibroid? Increased surface area of endometrium, increased vascularity and pelvic congestion. Interference with normal uterine contractility due to interposition of fibroid. Associated endometrial hyperplasia due to hyperestrogenism. Altered prostaglandin metabolism. What are the different treatment options available for fibroid? Surgery. Surgery में there is myomectomy and hysterectomy. Then there is medical therapy. Recent advances क्या है? Uterine artery embolization, cryomyolysis, and magnetic resonance guided focused ultrasound, MRGFUS. What is the role of medical management in fibroid? The indications for medical management are the following: to control menorrhagia, to correct the anemia, and to relieve the pain. The various drugs used are prostaglandin synthetase inhibitors, progesterone therapy, low-dose oral contraceptive pills, levonorgestrel releasing intrauterine devices, GnRH analogs, agonists and antagonists, anabolic steroids, danazol and gestrinone, antiprogesterone, mifepristone. What are the secondary changes in a fibroid? Yes, this is something they ask all the time. Degeneration. So there can be degeneration, hyaline degeneration, cystic degeneration, calcific degeneration, and red degeneration. There can be infection in the fibroid. There can be atrophy, necrosis, sarcomatous change, cancer. So what are the degenerations in fibroid? Hyaline degeneration is the most common degeneration. Cystic degeneration seen in menopause. Cystic spaces are seen within the fibroid. Fatty degeneration, calcific degeneration, womb stone, not tombstone. It's womb stone appearance. Red degeneration seen in pregnancy. Yeah, this is very important. This is an MCQ. Seen in pregnancy and puerperium. Atrophy usually occurs in menopause. Necrosis may occur due to inadequate vascular supply. Sarcomatous change can occur in less than 0.2% of cases. So now let's move on to the next specimen, gross appearance. This is a specimen of a cut section of uterus, okay, showing a well circumscribed lesion in the myometrium. It's not that clear, but ठीक है. Protruding into the endometrial cavity, thereby pushing and distorting the endometrial cavity. Diagnosis: the most probable diagnosis is submucous fibroid. Let's move on to the next one. Gross appearance. This is the specimen of cut section of uterus with a huge lesion arising from the posterior lip of the cervix. This lesion is from posterior lip of the cervix. The uterus sits on top of the huge mass. Lantern on dome of St. Paul's Cathedral. That's what it's called. Okay. The uterus is cut open to show the uterine cavity. Okay. Cervical fibroid is the most probable diagnosis. Viva. What can they ask you in the Viva? How is fibroid uterus differentiated from adenomyosis? So fibroid uterus usually observed in the reproductive age group, but adenomyosis is commonly seen in multiparous women older than 40 years. Fibroid, it's a benign neoplasia of the smooth muscle of uterus. And what is adenomyosis? It is due to the presence of functioning endometrium within the muscle layers of the uterus. So all the endometrial glands enter the muscle layers of the uterus, the myometrium. Uterus in fibroid is irregularly enlarged depending on the site size, number of myomas. Uterus is firm and non-tender on palpation. But on adenomyosis, uniformly enlarged uterus due to myohyperplasia, uterus is soft and tender on palpation. Symptoms in fibroid may present with menorrhagia and dysmenorrhea. In adenomyosis, menorrhagia may be present. Dysmenorrhea typically begins a week before and lasts even after menstruation ends. Diagnosis of fibroid is by ultrasonography, USG. Homogeneous echogenic area is seen over the fibroid. Cut section pe you'll see capsule which appears smooth and white with a walled appearance. Histology pe you'll see proliferation of smooth muscle and fibrous tissue. Adenomyosis. In adenomyosis, cystic spaces within the myometrium are seen. Capsule is absent. There is diffuse trabeculated appearance, cystic spaces with hemorrhagic spots. Proliferation of endometrial glands and stroma. Phagocytic cells laden with hemosiderin pigmentation are present. Pigment are present. What are the types of cervical fibroid? There's anterior cervical fibroid, there's posterior cervical fibroid, there's lateral cervical fibroid, and central cervical fibroid. Anterior cervical fibroid arises from the anterior lip of cervix. It may cause urinary retention because उसके आगे होता है what? Bladder. Posterior cervical fibroid may cause rectal symptoms, constipation. Lateral cervical fibroid, compression effect on the blood vessels and displacement of the ureter. Central cervical fibroid. Second question, what would have been the most likely clinical presentation of this woman? Women with cervical fibroid most likely presents with pressure symptoms. What are the gynecological pathologies where ureteric injury is more likely to occur during surgery? So if this is surgery for cervical fibroid, broad ligament fibroid, pelvic endometriosis, gynecological malignancy, so you can expect a ureteric injury. Specimen number 10. So this is a cut section of a specimen of uterus showing a pedunculated mass protruding into the uterine cavity near the fundus. Where is it? Okay, this thing over here. The most probable diagnosis is pedunculated submucous fibroid polyp. What would be the clinical presentation in case of a fibroid polyp? Menstrual abnormalities like menorrhagia, dysmenorrhea, metrorrhagia, pain in abdomen. How will you diagnose this case? Speculum examination. The pedunculated polyp can be visualized if it is protruding through the cervical os. Ultrasound examination, saline infusion sonography, hysterosalpingogram, filling defects in the cavity, hysteroscopy, direct visualization, removal of the polyp can be done. Next specimen. Okay, this one. Chocolate cyst. Anyways, the mounted specimen shows a cut section of ovary. The inner surface contains area of dark brown tissue suggestive of clotted blood. The outer surface of ovary appears to be thickened. What are the common sites of pelvic endometriosis? Ovaries, most common. Then pelvic peritoneum, pouch of Douglas, rectovaginal septum. What are the treatment options for pelvic endometriosis? Expectant management, medical therapy, surgery. Surgery can be conservative or definitive. There can be combined therapy, that is both medical and surgical therapy. What are the hormones used in the management of endometriosis? Combined oral contraceptive pills, progesterone adaptogens like oral IM or LNG, levonorgestrel, IUD, danazol, and gestranone, GnRH analogs. What is the management of chocolate cyst? This is a chocolate cyst. Small endometrioma hoga, less than 3 centimeter, then laparoscopic cyst aspiration, destruction of the cyst wall, epithelium by diathermy or laser can be done. If large endometrioma hoga, more than or equal to 4 centimeter, then ovarian cystectomy with adhesiolysis can be done. So the diagnosis, the most probable diagnosis is endometriosis of the ovary. Okay, this specimen, endometrial hyperplasia, okay. Specimen shows a cut section of uterus with the cervix. This cervix is uterus. Endometrium appears irregular and thickened with areas of hemorrhage and necrosis. The most likely diagnosis is endometrial hyperplasia or endometrial carcinoma. So, specimen 13. This one. It's so blurred, but theek hai. Anyways, gross appearance. Specimen shows a cut section of uterus with cervix and bilateral adnexae. What are the high risk factors for endometrial cancer, carcinoma? Nulliparous woman, late menopause, persistent unopposed estrogen stimulation of the endometrium. Corpus cancer syndrome. What is corpus cancer syndrome? It consists of obesity, hypertension, diabetes. Atypical endometrial hyperplasia, tamoxifen therapy, family history of ovary, breast, or colon cancer. How will you diagnose a case of endometrial carcinoma? So, history in all cases of postmenopausal bleeding and perimenopausal abnormal uterine bleeding, AUB. Cervical and endometrial carcinoma to be ruled out. Transvaginal sonography, endometrial sampling is recommended if endometrial thickness is more than or equal to 4 mm in postmenopausal women. Fractional curettage of hysteroscopy directed biopsy is performed. The endometrium appears irregular and thickened with papillary projections and areas of hemorrhage and necrosis. Computed tomography, CT, and magnetic resonance imaging are used to identify myometrial invasion and spread of tumor. What is the most common histological type of endometrial carcinoma? Adenocarcinoma. Endometrioid 80%. What is the management of endometrial cancer? Most patients are identified in early stages. Surgery is the first line therapy. Total abdominal hysterectomy, extrafacial hysterectomy plus bilateral salpingo-oophorectomy, oophorectomy. Pelvic and para-aortic lymph node sampling is done. Clear cell and papillary serous carcinoma performed. Omentectomy and peritoneal biopsy in addition. Adjuvant radiotherapy is given following surgery for prevention of recurrence. So the diagnosis, the most likely diagnosis is endometrial carcinoma. Let's move on to the next one. Let's look at the specimen first. This is the specimen. Okay. A mounted specimen shows a cut section of ovary with a large mass. There are multiple septae which give it a multiloculated appearance. Okay, there are no solid areas within the mass. The loculi appear to be empty, probably because the contents have been washed out during mounting of the specimen. The specimen prior to mounting may show loculi filled with thick viscid mucin-like material. The most likely diagnosis is benign ovarian neoplasm, probably a mucinous cyst adenoma of the ovary. The diagnosis needs to be confirmed by histopathological examination. What are the clinical features of benign ovarian tumors? Slow growing, unilateral, mobile, cystic in consistency, smooth surface, no ascites. Differential diagnosis of abdominopelvic mass in reproductive and perimenopausal age groups: full bladder, pregnancy, fibroid uterus, adenomyosis, chocolate cyst of ovary, tubo-ovarian mass, encysted peritonitis, which is seen in tuberculosis and ascites. Let's move on to the next specimen. This is the next specimen. Okay. The specimen shows a cut section of ovary with a large cystic mass. External surface appears smooth. The capsule appears thin, translucent, and glistening. The cut section shows few septations. There are no solid areas or papillary projections. Normal ovarian tissue can be visualized. The most likely diagnosis would be a benign ovarian neoplasm, probably a serous cyst adenoma of the ovary. A histopathological examination is required to confirm the diagnosis. So what are the common complications of benign ovarian tumor? Torsion, intracystic hemorrhage, infection, rupture, Pseudomyxoma peritoni. We have this in surgery also, in appendicitis. Malignant change. Next specimen. This is the next specimen. Where is it here? Okay, this is the next specimen. Gross appearance. The specimen shows a cut section of an ovarian cyst. The cut section shows a sebaceous material and hair. There are no solid areas or areas suggestive of hemorrhage or necrosis. The most likely diagnosis is dermoid cyst of the ovary. A histopath examination is required for confirmation of diagnosis. So what are the questions they can ask you? What are dermoid cysts? The dermoid cysts are mature teratomas with a variety of internal contents such as hair, sebaceous material, teeth, bone, cartilage, thyroid tissue, and bronchial tissues. This leads to anechoic to echogenic appearance in USG. Dermoid cyst is the most common germ cell tumor. It is the most common benign ovarian tumor. It is the most common benign ovarian tumor in pregnancy. Contains derivatives of ectoderm, endoderm, and mesoderm. The most common element is ectoderm. So what is the risk of malignant change in dermoid? The risk of malignancy is 1 to 2%, usually is squamous cell carcinoma. What is the most common complication of dermoid? Torsion of dermoid cyst is the most common complication. Let's move on to the next specimen. This is how it looks. Okay. Okay. This is a specimen of an irregular shaped huge mass that appears to arise from the ovary. The cut section shows tissues with varied consistency. Solid areas are seen within the mass that indicate that the mass is likely to be malignant. In some specimens, areas of hemorrhage, necrosis, and multiple blood vessels can be seen traversing the surface of the ovary. So, what are the common malignant ovarian tumors? Epithelial ovarian tumors can undergo malignant changes. Serous cyst adenoma to cyst adenocarcinoma, mucinous cyst adenoma to cyst adenocarcinoma, 10%. Malignant endometrioid rare. Germ cell tumors are usually malignant. However, dermoid cyst is mostly benign with 1 to 2% risk of malignancy. Sex cord stromal tumors may be benign but are potentially malignant. What is the primary surgery done for malignant ovarian tumors? Exploratory staging laparotomy, total abdominal hysterectomy, bilateral salping oophorectomy, and infracolic omentectomy with pelvic and para-aortic lymph node sampling are done. If tumor is not completely resectable, cytoreductive surgery is done that reduces the tumor load. Less the residual tumor volume, less than 1 centimeter, better is the response to chemotherapy and better is the survival rate. How is serum CA125 measurement helpful? Serum CA125 is a glycoprotein and has got more prognostic value than diagnostic value. It's helpful in the following ways to assess the prognosis in a known case of ovarian tumor, to know the response to treatment, and for early detection of tumor recurrence. Name some solid tumors of the ovary. So benign solid tumors can be fibroma, thecoma, Brenner's tumor, and malignant solid tumors can be primary epithelial ovarian carcinoma, dysgerminoma, and mesothelioma. Okay, what is Meeks syndrome? It's a triad of ascites, pleural effusion, and benign ovarian fibroma. The ascites and pleural effusion resolve spontaneously once the ovarian tumor is removed. If ascites and pleural effusion are seen in association with Brenner's tumor or granulosa cell tumor, then it is known as pseudo-Meeks syndrome. They asked me this in my medicine practical Viva. They asked me about Meeks syndrome because I had a case of ascites. What are the hormone-producing tumors of the ovary? Feminizing tumors, granulosa cell and theca cell tumor. Masculinizing tumors like Sertoli-Leydig cell and Hailey cell tumor. So diagnosis, the most likely diagnosis is a malignant ovarian tumor. However, this needs to be confirmed by histopath examination. Let's move on to the next specimen. This one. Okay, this is next specimen. This is a specimen of uterus with tubes and ovaries on both sides. The ovaries are enlarged with lobulated appearance. The shape of ovary is maintained. Uterus and tubes appear normal. The most likely diagnosis is Krukenberg tumor. What is Krukenberg tumor? This is a metastatic adenocarcinoma of the ovary. Metastasis is from the stomach, most common breast, colon, or biliary tract. The tumor is usually bilateral, lobulated, and solid in appearance and with smooth surface without any adhesions. Prognosis is poor with a survival rate of less than a year. What is the mode of spread of tumor to the ovaries? Retrograde lymph. This is also asked so many times. What is the mode of spread of tumor to the ovaries? Retrograde lymphatics and transcelomic spread. Retrograde lymphatics and transcelomic spread. Okay. What is the histological picture of the tumor? The signet-ring appearance of epithelial cells is characteristic of Krukenberg tumor. Specimen of uterus with cervix. So this is the next specimen, as you can see. This is a specimen of uterus with cervix. No adnexa is visualized, hence adnexa has probably been retained during hysterectomy. Obviously, cervix appears to be elongated. Yes. Elongation of supravaginal part of cervix is commonly associated with uterine prolapse. The most likely diagnosis is supravaginal elongation of cervix. The probable cause, prolapsed uterus, can be identified if the patient's history is provided. So what can they ask? Why is supravaginal elongation of cervix present in uterine prolapse? So elongation of the supravaginal part of cervix is commonly associated with uterine prolapse. The elongation occurs due to a pull of the cardinal and uterosacral ligaments on the isthmus of cervix to keep the cervix in position. So yes, we are done with all the specimens in gynecology. So that was part 2 of the OBGY specimen series. If you found it useful, please let me know in the comments below. And part 1 is live. It's about the obstetric specimens, all the obstetric specimens in one video. So do watch that. And please subscribe. And goodbye. Bye-bye.